the other thing that you're facing in the UK is that the National Health Service is undergoing lots of change as well, simultaneously. As a matter of fact, many organizations in the UK are really looking to the example that Imperial College is bringing, some of the other institutions as well, to the table. Can you talk a little bit about what those changes are and where you see things going? Because some people observe that the UK is starting over here with this National Health Service, which is not as monolithic as people think. It's more of a federation.
Yeah.
And we've got this laissez-faire kind of approach, and that in fact the two countries are kind of coming together. What's your thoughts on that?
Yes. If you go back 10 years, the way in which all of the organizations, probably 10, 15 years, the way in which every organization in the country was run, it was run in a very socialist system. In other words, the Secretary of State and the Department of Health were responsible for every single health organization in the country, whether it be a hospital, primary care trust. At the end of the day, if you were missing a target, if something had gone wrong, that would be fed right the way up to the Secretary of State and the Permanent Secretary, who's the senior civil servant, and the system would then cascade that down. So you can imagine every decision having to be taken by somebody else. So it created a dependency culture, because if your organization was losing money, because it's a socialist system, then you take it from somewhere else which is doing well. So there was no incentive whatsoever to be in surplus of your particular part of the nationalized, because it's called the National Health Service for that reason. There was little or other mechanisms to be financially rigorous, because it came from taxation, and when you're spending at that time 30 billion, 60 billion US 10, 15 years ago, there were always apparatchiks who would come and bail out the poor ones and take away from the senior. So essentially under the Thatcher government initially, they firstly tried to introduce management structures into health, very much at the same time as I think in the States you introduced more of the HMO type system. And Thatcher introduced a more business approach to health. But they excluded the professions, because the profession was seen to be a hindrance to modernization, and probably not an awful lot's changed.
Yeah, right. Right.
So that started a political change, and then in Blair's administration, which was 11, 12 years ago now, they moved it on to a mechanism whereby those structures continued to get independence, and as you say, Kevin, into a more federated structure. And there has been a big debate as to whether these things can go bust, whether they can be taken over, what degree of independence they should have. On the other hand, as we've all seen with banks, at the end of the day, health and banking, the government at the end of the day is the lender of last resort. And the economic events of the last 12, 24 months have had indirectly quite an interesting impact on healthcare. The other bit is that Britain has doubled, roughly, and it may not seem it for those contracting with the health service, but over the last, since 1997, health expenditure in Britain has doubled, so that it's now about 9 to 10% of GDP. I know it's less than in the States, and it's pretty close to the European average, which was a pledge Tony Blair gave in front of the newspapers, on television, without having discussed it with anybody else in Cabinet or in the Department of Health or the Treasury. So it's coincided with a substantial increase of funding.
Now, with all those changes that are occurring, one of the issues that is clearly, I know, on the front of your mind is the whole issue of leadership and leadership development, and how are we going to manage this? Because it really, I think you're moving into a new era where the trusts are really having to operate very differently than they have historically.
Yes.
And so what are the leadership challenges that you're facing as you begin to move the organization forward?
Yeah. Well, there are two obvious leadership challenges. The first is you have a whole cadre, a whole mechanism of finance officers, operation officers and so on, who are not what you would understand as finance officers or operation officers. 10, 15 years ago, and still I think to today, these people are best described, in my opinion, as apparatchiks. They are the same types of people who would run a socialised system. The British system was probably one of the most socialised healthcare systems in the world. Even Chairman Mao did not introduce socialised medicine, and the Russians never got actually anywhere near it. We had a system, free at the point of access, fully funded from taxation, in which the people who functioned in that are civil servants. They're employed by the government. They have, like myself, a very large pension. There is little or no insecurity. It's almost impossible to be fired. It created a culture and a system which was difficult. Now, of course, in moving to a different culture, this is going against in some respects, very deeply held personal and political views of many of the individuals. Plus, of course, they don't have private sector expertise. Right. So we spend much of our time hiring individuals from the private sector, not to mention employing systems like Perot and Cerner to actually provide a degree of private expertise in healthcare into the system. Now, politically, the agenda's reasonably even at the moment. I don't think the great British public, or GBP as they're known, want to go back to the system in the past. But having put all of this money into the system, it still, as we all know, takes a heck of a long time for the patients to notice a difference. And there's a difficult position at the moment as to whether all this money and this change has been worth it. Mm-hmm. On the other hand, I don't think it's going to sink back into the leftist policies of the previous 60 years. Mm-hmm.
Let's shift course a little bit. I was down in Abu Dhabi recently, and I was sharing with you that I was in Abu Dhabi driving to Dubai, and all of a sudden I saw this building on my left, Imperial College. You have a clinic down there, and I know that one of the things that you're beginning to explore, along with Johns Hopkins, Cleveland Clinic, a variety of other, Harvard, are also looking at sort of a global delivery of services. Tell us a little bit more about what your thinking is around that and where Imperial College is headed.
Well, we are certainly looking at the international perspective, and up until we had formed this new entity, it was not possible for UK organisations to really compete against Hopkins, Harvard, and so on, because we had two separate entities. So you could go out as a university, and as a university you can talk about research, PhDs, degrees, medical students, but you couldn't talk about service. So there's not much point in having a professor of OBGYN if they can't do service and they can only do academe. On the other hand, NHS organisations and trusts do not have a pot of money or a board, or didn't. They would have to ask the government, and therefore if you set up an NHS hospital or a partnership, that would have to be at essentially a governmental level between what is the Department of Health and the government of whichever country it is. It's only since we were able to form this newer entity that we're able to actually go, just like Hopkins or Mass Gen or the Cleveland Clinic, and provide an operation which can be both clinical service and research. Now, our reasons for doing that are reputational, because if you want to be seen as a global player, you have to play on the global scene. It's also strictly financial. The British government, through taxation, is likely to increase research expenditure by 2 or 3% above inflation, maybe more in some years, 1 or 2%. Whereas this is not going to allow one to get substantial sums of money for either patient benefit or for research. And so clearly we are looking at the international environment where we can actually enter as a business into providing research, education and service, but as a business. And as a business we want to make a profit, and we want to use that profit for the benefit of the organization.
So if you look ahead 10 years, just look into the future, and what's your prediction about where healthcare is going to be going from a global standpoint? How's it going to be organized? We've got CEOs here of some of the largest systems in the country. What are the challenges that they're going to be facing as we see globalization, as we see medical tourism, as we see the evolution, if you will, of India and China and other places?
Well, I think there are two major challenges. For a centre like mine, which is an academic medical centre, then in a sense the world is already globalized. As we all know, the top 6 neurosurgeons in the world are the top 6 neurosurgeons in the world, and they could be in several different places. Probably a few more diabetologists and cardiologists, but it's a completely global world, and therefore the battle of the clusters, if you like, and the Boston cluster, the Bay Area, North Carolina, southeast of England is a strong cluster which we're trying to pull together to compete. This is a competing mechanism. So I think from the academic point of view, we are already into the era of global competition. And I was at an AHSC meeting a couple of months ago, and I think there are something like 72 to 80 US operations worldwide in which centers have some sort of collaboration with the rest of the world.